For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 4, Episode 6 of Surfing the NASH Tsunami. Our introduction to NASH and NAFLD Down Under starts now.
This week on Surfing the NASH Tsunami.
Primary care is clearly where it is all happening, but in terms of the volume of patients these people see, the variety of patients they see, it may not be at the top of their list of things to do.
I did a series of around about 80 scans here in Perth, largely higher socioeconomic, largely people have access to fitness and health and would consider themselves relatively fit and healthy, and 33% had high liver fat.
By 2050, these numbers of people who by that stage will be cirrhotic will be huge, and the biggest transplant programs in the world will not be able to cope with these people, and it's really now that people have to start thinking about it.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join liver wellness advocate Louise Campbell and her guest, Australian hepatology researcher and key opinion leader Dr. Tony Rahman, as they discuss fatty liver patient management, diagnosis, and treatment in Australia on today's special edition of Surfing the NASH Tsunami.
Welcome to Episode 6, our introduction to fatty liver disease in Australia and New Zealand. You might be surprised to hear my voice, since I mentioned last week that this is my vacation week. You might also be surprised when you learn how short this episode is. Not surprisingly, those two items are related. As Louise was recruiting this episode last week, a medical situation arose at home that required her full-time attention. She was able to recruit Tony Rahman, one of the leading hepatologists in Australia, to conduct an interview for the podcast, and she had several other folks to follow up on once she got to Australia. Unfortunately, the same situation that required her not to work on this the week before the episode meant she had to turn around and fly back to Australia shortly after she arrived. So, for this week's podcast that we are now calling Introduction to Australia, we have an informative 35-minute session with Louise and Tony. I particularly like the different ways that they focus on patient treatment and how do you get patients in a country that is as geographically remote and distant as Australia is. Now, since Louise is not in Australia, next week's topic will change as well. I just got back to work today, so I'm working towards next week now. We'll have a fuller series of episodes on Australia when Louise is able to get down under again, probably in March and April. And just a reminder, when you're done, if you like this concept, or if you have questions about it, or challenges, or even if you don't like it, please leave a comment or question as a review in your podcast app. All reviews come to us. We'll reply, sometimes by reading them on the podcast, sometimes by inviting you to join us to ask, sometimes simply by email. All that, as I've mentioned in previous episodes, will help boost our ratings. And without further ado, here are Louise and Tony.
Today I've got with me Dr. Tony Rahman, who's Director of Gastroenterology and Hepatology at the Prince Charles Hospital in Brisbane. And prior to this, in Brisbane, you were a consultant gastroenterologist, hepatologist and physician at St George's in London. My understanding is your special interests nowadays are endoscopy, colonoscopy, all things liver disease, NAFLD, NASH, viral hepatitis, Hep C, and you were awarded the Doctor of Philosophy of Medicine at Imperial College back in 2003, one of my old stomping grounds, Imperial. And following 3 years of that, researching mechanisms, novel therapies and acute liver failure at the Royal Postgraduate Medical School at the Royal Free Hospitals in London. But I know you from King's and some time we spent together at King's College Liver Unit there. And you've got about 119 publications the last time I looked under your belt, and a number of citations. So take a few minutes to introduce you more than that and tell us exactly how you got into this space and what you're doing currently.
Well, it sort of started like most medical journeys, lots of luck and accidents and left turns and right turns to end up where I am. But originally my aim was to be an ICU physician. And so I went up that pathway and ended up on the liver unit actually to work with one of the ICU physicians there. And then it just so happens that the specialisation programs came in and I got calmanised into gastroenterology, which actually it wasn't really what I wanted to do. I thought, well, okay, that's fine because there was no ICU training pathway. And then eventually did that in London, went off and did a PhD, came back into gastroenterology gastroenterology, did a couple of years as an ICU senior fellow, and then got a job at St George's where I was a sort of ICU physician and gastroenterologist, which is quite good because I ended up generally dropping adult general medicine. And so in terms of the next 10 years, it was really spent looking at predominantly the sort of sicker end of liver disease, predominantly on ICU, but also the way the rosters worked. I actually did a lot of clinic and a lot of endoscopists because when I wasn't ICU, I'd be just doing gastroenterology, not having to look after too many patients in general medicine. And in that time, did a sort of broad area in terms of looking at research projects and what was going on. And I suppose that's the beginning of that NAFLD period, really, or fatty liver disease, because that's when the transition started to happen. So this is going back to about 2000, 2004, when you started to notice that liver disease clinics, which were predominantly alcohol, 70-80% alcohol-based clinics, were changing. And then at that point, I'd probably estimate things to have been, about 60-40 alcohol versus fatty liver disease. Then as time went on, I actually then decided to do a year abroad, and that was to go to Australia and got a job at the Prince Charles, which is in Brisbane, which is a small hospital, but it's the regional or state lung heart transplant hospital. So there's quite a lot of really very peculiar, unwell, weird liver disease going on there. And we've basically spent the last 10 years now, I've been here 10 years, setting up their liver disease services. So prior to me arriving, they didn't really have very much in terms of a dedicated service, whereas now we have, an adult congenital heart disease liver clinic, we have a cardiac disease liver clinic, we have combinations of the standard sort of services that any hepatology service would offer. So the fatty liver disease, viral hepatitis, and so on. But in a sense, I think I've been very fortunate, like many people of roughly my age, because we've seen so many changes that have taken place in the last 20 years. And I suspect everyone can say that of their period of 20 years. But, the revolution that's gone from struggling to get people to have Hep C treatment, curing Hep C, even with Hep B, the transition that it's made in terms of saving people's lives, reducing cirrhosis, reducing HCC with Hep B drugs, and obviously this new onslaught of new liver disease, which is gradually replacing everything else. So, in the last 10 years, in Australia, things have been slightly different from the point of view that we've had to really gear the service towards the patients, and there has been a little bit of resistance. Like in all established systems, if you want to change something, there is a bit of resistance that you have to come up against. So we've done a variety of things to try and facilitate treatment for Hep C, for example, where we treat people now without seeing them, and so the GPs just send us some information. We mentor the GPs, have like a 24/7 service for information, and then they can treat the patients, and if there's any problems, they contact us. So that's been great because, we started this in about 2016, and so we've done this for Queensland, some patients from New South Wales, and then we sort of about 4 years ago started in the local prison. So that's been great, and then we extended that. We thought, well, actually, this is quite a good approach, and it's been well accepted by the patients because they don't have to travel. In Queensland, the travelling is a big problem because some people will be travelling 10 hours to come to you to see you in clinic for half an hour, and then that afternoon travelling back again. Probably Western Australia is the same. So then we thought, well, how can we change our approach to NAFLD? And we looked at the provision of services in local treatment centres, for example, and then we sort of explored that for a bit, but that was staff heavy. And eventually we basically employed the models they're using in London, like the Sheffield and the North London model with Rosenberg and Tal. And so we've got this traffic light system that we've set up. That little project is running for NAFLD, which is then facilitating people being treated and discharged, so we're not having to see everyone. Because as I mentioned, I think the ratios in clinic now have completely changed. So I would say that in our clinics, we probably get about 60% fatty liver disease and 40% everything else, because obviously the Hep Cs and the Hep Bs have generally gone. We tend to do that on a telehealth basis now. And so the patients coming, the predominant patients are all the fatty liver disease that need to be assessed, and some of the serious ones that obviously require further follow-up. And the alcohol cohort, I think, is shrinking. So we've spent the last 10 years really trying to refine what we have to fit the population burden that we have, which is huge. But the specific challenges we have are really around the patient's ability to attend, their financial situations, which might limit them, and that sort of thing. And then we're sort of now looking at other areas of interest, that sort of green endoscopy space where how we can be a bit more environmentally friendly. So we set up a telehealth platform, for example, to try and encourage people to be a bit more well-informed before they came to clinic. We've set up a NAFLD-based dietetic program that runs over 12 weeks. Again, that's all on telehealth, so patients don't have to come to the hospital. And actually, we did all of this pre-COVID, so when COVID came along, we actually had a very interesting experience because a lot of our stuff was already telehealth-based anyway, so none of our stuff stopped. Whereas I know in other hospitals, all of the non-essential stuff pretty much stopped. We continued because all of it was non-patient facing and wasn't putting anyone at risk. And I've sort of waffled on there for about a few minutes about stuff that's general, but I think what it does, it gives you a little flavour of the fact that having been established in London for 10 years, then to reinvent yourself in another place requires you to look at the problems that this other place has and try and find solutions that are specific. And I suppose the broader message is that really it's constantly trying to refine what you do to improve clinical pathways. And I suppose that's probably what I've done in the last 20 years, really spent my time trying to refine clinical pathways and improve patient outcomes.
Fantastic. And I am going to come back to some of those initiatives. But we always get any new surfer onto the programme to give us a little snippet of something that most people wouldn't know about you. And we've had from running with the Bulls at Pampaloma to being professional basketball players, musicians, wearing gold lame shorts and doing a Take That impersonation. So come on then, Tony, what are you going to surprise me with?
I mean, I've probably got a lot of things that you'd probably be surprised, actually, that many people wouldn't know, but some of it probably isn't appropriate for podcasting. But whenever I meet people and they get to know me, they sort of think, right, okay, well, this is clearly just an average bod, a normal bloke. But I used to actually be quite a big rugby player, and I actually used to be a pretty serious full-on prop forward. So prop forwards on rugby fields tend to be short, or used to be anyway, short, squat, fat, very aggressive individuals. Up to about the age of 30, I played pretty serious level rugby and played rugby with internationals, played a few big games for a couple of big clubs. But yeah, that's probably my sort of secret, that most people, when they meet me now, they just cannot believe, because I've shrunk a lot as well. I've lost about 20 kilos in weight. So no one can actually believe that I used to play pretty serious rugby.
Well, given I knew you quite a few years back, I would have still never put you as a prop forward.
Yeah, I know. I think it was at the time when prop forwards was beginning to change, and prop forwards who were a bit faster and a bit leaner and a bit lighter was becoming a bit more fashionable. So I was definitely quicker, faster, and had a bit of strength. But that's, again, it's one of those things that most people wouldn't realise.
No, but it's great information for the Americans who do American football. I'm sure there is a position that's fairly similar, aggressive thing, but without the padding. Well, they wear more padding than you. But just going back to some of the interesting stuff you've said, because I will come on to that sort of dichotomy of type of health service, so NAFLD and NASH is now growing, and I think you've been saying that it's now the biggest population that you see within your clinics.
I think without a doubt.
But I don't get a sense that we actually know how big the population is in Australia, or the percentage, and we tend to divert to the figures by UNOSI, the averages taken over populations. Do you deal with a lot of the Aboriginal population who obviously have high metabolic components? And do you get a sense that that's driving some of the fatty liver population within Australia percentage-wise, or is that a different cohort that has a bigger risk or a less risk?
I think that's a very interesting question. It's a very difficult question to answer, and it's a very difficult question for me to answer because I think my experience has only been really 10 years in one hospital in one part of Brisbane. And what I've come to realise is that I came to Australia thinking, well, I might spend a lot of my time working with the Aboriginal community and trying to help their sort of healthcare needs. But certainly in Brisbane, my hospital, which is probably about 12 kilometres, 15 kilometres from the city centre, but still within the city boundaries, we actually don't see that many Aboriginal people coming to this particular hospital, despite the fact that the community just beyond us has a large number of Aboriginal people. And so that bit of your question, I can't really answer that based on my personal experiences. But if we then look at the data that is available, which is a little bit limited, we have got some ongoing projects with James Cook University, which is based in Townsville and in Cairns. And we were doing a little project looking at patients with diabetes, and some of the patients or some of the people in the study were actually recruited from many of the Aboriginal communities. And the incidence of fatty liver disease was moderately high. I couldn't really give you that data with confidence because I think it's complicated by the fact that there isn't much other health data around their other factors that might be influencing whether the fatty liver disease is really just metabolic or whether there may be other factors involved in precipitating that. Certainly within the cohorts that we see and the information that we have available, I think the latest sort of general update was from GISA, and they were looking at the AIHW data that came out of 2020, which is the health and welfare data that comes, it's available online. And I think the estimates were that it was about 20 to 25% of people within the whole of Australia, as opposed to subpopulations. And then the estimates going up to 2030 were saying that as many as 40% of people. I actually think 25% of people was quite low, because if you look at the obesity numbers for Australia, for the UK, for the US, I think the top three countries are those three countries. And I think the estimates are generally that about 1/3 of people in Australia are above the recommended weight. And I suspect that with the recent broadening of definitions going from NAFLD to MAFLD, then if you start including people who aren't necessarily overweight, who have risk factors such as high cholesterol or high triglycerides plus diabetes within the MAFLD category, then I suspect that your numbers will be significantly higher. I personally, when I talk to people, I would say the estimates in Australia are going to be up to 40%, if not more, already. But there's nothing to support that apart from my own general thinking.
Well, I think it's interesting. I did a series of around about 80 scans here in Perth, largely higher socioeconomic, largely people have access to fitness and health and would consider themselves relatively fit and healthy, and 33% had high liver fat. So this wouldn't be your normal. Yes, there were some larger than average, and I think Western Australia does qualify as the slimmest state in Australia. Queensland second to Tasmania in the highest level of BMIs. It surprised me that it was that high in people that you wouldn't consider predominantly at risk. I think the one thing that I did take away, because of course these are people who have chosen to look to see if they've got liver health and engaged very well with it, but what concerned me was the 9% who had elevated stiffening, and anybody who was extremely high was postmenopausal woman. And obviously, as you suggested there, the more the risk factors, cardiometabolic, diabetes, were evident, the higher the level of liver fat. So that didn't surprise me. But going on to some of the figures that were released this year, in July 22, wasn't it? The Australian health figures, they concentrated on cardiovascular, type 2 diabetes, and yet still made the comment that these rates aren't falling in mortality, even though the numbers, and we're managing it better. And I just wonder that's because we've ignored the liver throughout that elephant in the room. And now I know you go out on a really great initiative, Heart of Australia, which is so tell us a bit more about that, because most people won't know about Heart of Australia who are going to listen, and how that really buys into how you get liver care and location out.
So the Heart of Australia is an initiative that was set up by a chap called Rolf Gomes. And Rolf Gomes is a cardiologist based in Brisbane, and he is essentially set up as a business from the point of view, it's not a charity, but it's a business that he runs. And so what he was trying to do was actually take healthcare to regional Australia. And again, for people who haven't worked here, and I was one of those people, I didn't really understand the challenges that entails. So within our clinics, for example, at Prince Charles, we'll be seeing people from Cairns, so that's 2,500 kilometres away. They'll come down for a couple of days. We've got people from all over Queensland. So for people to access healthcare, they have to generally go and travel long distances to see specialists. And so what he's done is invested in these double trailers or double semi-trailers, and he's converted them into consultation suites and also a cardiac lab and a sleep lab. And so the first truck, which was called Heart 1, basically every month does about 9,000 kilometres on this circuit going through central Queensland. So it'll stop in a small town. The town's GPs will know that this is coming. They'll book up appointments for them to see the cardiologist, to have exercise ECGs done, ECGs, sleep studies, that sort of thing. Then I joined him in year 2, and then we started doing clinics and also FibroScans. And so that was a great addition, but there's only one of me at the moment, so I can only do 3 days every couple of months. And now he's up to 5 trucks. So he's now got endocrinologists on board, he's got gynecologists on board, psychiatrists on board, general physicians. So now there's a service that actually goes all the way, before it was mainly sort of southern Queensland, now it goes all the way up to northern Queensland, covering some of the Aboriginal communities in Palm Island, going up to Mount Isa. And he's also set up, interestingly, a program that goes to the mines to do mine health checks. So again, in terms of a service that's really quite unique, it's one of a kind. I think he's in consultation. I mean, at some stage, it might be worth you having an interview with him, actually. He's an amazing chap. But I think he's in consultation with the Western Australian government to introduce something similar there. So it's only a very small service from my perspective, but we do get to see, over a period of 3 days, 20, 30 patients, generally who've been referred by their GP. So it's not a walk-in service at the moment. They would have to have a referral to come and see us. But very, very successful.
I love that type of initiative. We talk a lot on the podcast of what we can take from healthcare in different regions to apply to particularly third world and middle income countries who do not have access to technologies that we've got now and the future coming medications, which I will come on to shortly. And I think these type of initiatives are huge because you can go around, you can take that out, you can get, I would hope, investment and buy-in, because to keep people healthy is the way to save healthcare as well as lives and working families. You touched on it earlier, is also the fact that Australia lends that shared care system. When I worked in Sydney, we did very much, as you were doing there, that virtual type clinic back in the early 2000s where patients, instead of travelling every appointment 6 to 10 hours to see us for 20 minutes or half an hour, would only do it once a quarter or once every 6 months to collect their medication, and we would do everything remotely in that whole sense. There are certain aspects like that I think lend into very well if we establish NAFLD in Australia, as we know the numbers, we know the figures. That shared care system. Do GPs want to buy into NAFLD and NASH and want to know the education as well as they did for hepatitis C and the programs that you did there?
I think the answer to your question is yes. Like most things, it's about how you present the problem and how you present the solution and the benefits to the GP and the patients. So just bombarding the GPs with education isn't necessarily the best way of getting the most out of the system. If you want to change things, you have to go with a reasonable plan that has been looked at, tested, and is robust, because what you don't want to do is try and set something up that then doesn't work. So it's really about making sure that whatever you're going to introduce, it has been tested in that environment, albeit, when I say tested, even just as a sort of GP focus group tested, that this is something that is acceptable. I mean, to give you an example, when I set up the Hep C side of things, I based it on the Project Echo model from Mexico. So we set up the remote teaching, and once a week we set up 4 hours of teaching where GPs could log on with their cases, just like the Project Echo thing. But this wasn't Project Echo because you had to go and get signed off by Project Echo. This is going to be our Project Echo Lite model. But what the GPs said when I initially presented it was that no one had time to spend 4 hours having a teaching session once a week, because what other people in other countries may not realise is the GPs here get paid per patient they see. So time away from the patients is loss of income, and the GP remuneration, again, it may be different in Western Australia, is not great. So the GPs generally have to work quite hard to earn a decent salary. So again, the GPs are very interested. And so what we did at Prince Charles, for example, when we tried to introduce this traffic light system to try and keep less unwell patients at the surgery and bring the more unwell patients into the limited spaces that we have in clinic, was really to sort of say to them, well, look, you might be seeing these people and then you're worrying about their liver function tests for years before you refer them. What we can do very quickly is get them in, do a fibroscan, do a screen, and tell you immediately that this person is unlikely to have any liver disease or any problems for the next 5 to 10 years, in which case you can actually stop seeing them. Or if you don't necessarily have to stop seeing them, because obviously if you see them, perhaps that's income generator, so you don't want to stop seeing them, but at the same time, you can then stop worrying about them. And I think they like that this approach of meaning that they still could see the patients and they could still order the blood tests every 6 months, which I think is appropriate, but they didn't have to worry about them too much. Because as you alluded to, amongst that cohort, which is getting bigger and bigger and bigger, there will be patients there who will actually have significant liver disease that are overlooked because they don't have any obvious signs of it. So I think they bought into that, and that's what was popular. Then, as I mentioned, we tried to do FibroScans in some of the larger centres. So we would go out, so our FibroScan nurse, for example, would go out to one of the healthcare centres and start trying to do FibroScans there to save the patients having to come in. The GPs would go and cohort them on a weekly basis. But what we found was that it wasn't actually that efficient. And so rather than her potentially doing 10 FibroScans in a morning or more in the clinic at Prince Charles, there were sort of dribs of drabs of 1 or 2 or 3 or 4. So that actually for us didn't really work. So we've learned as we've gone along. What we have now is a fairly good model that suits our local GPs and suits us. But again, it's constantly being refined.
I think that's the key, isn't it? To constantly refine. We usually have Jean Schattenberg as our KOL on the podcast, and he's involved with Jeff Lazarus in doing some of the new pathways for NAFLD and NASH, and they've got the Barcelona meeting in May. And what I'm taking from this, there are certainly great pockets of where this works remotely with the primary care physicians, even if we're not picking up all of the patients. And I think APASL was one of the first, if not the first, major body to use FIB4 followed by FibroScan. And if you can get it into a primary care sort of setting, use that, which has then been followed on across Europe and now with the American guidelines, AGA. And I think we're all moving to it. Yes, FIB4, we discuss regularly, isn't always the best, but it's better than we've had. Is it something that's used a lot here to stratify, or is it something that's just coming in and starting to get traction, or is it not really making any headway?
I think it's making headway. Right from the outset, really, the education that we've been providing is about using APRI, FIB4, and obviously that really came on the back of all the Hep C stuff that happened 5 years ago, 6 years ago, in terms of trying to get patients put forward for Hep C treatment. And so the GPs are familiar with the fact that these online calculators are available and they're very easy to use, and the risk stratification is good. Because actually, if you compare it to nothing, it's actually excellent. But I still think that, if you're in this world and you're using this stuff all the time, it then gives you reassurance that it actually does work. But also, what you do learn is where potentially it doesn't work. So when you see a slightly odd result, you can look at it and say, well, actually, that doesn't quite make sense. I'm going to look at this a little bit more. And I think that comes with looking at these things all the time. And it's a bit like using a FibroScan. FibroScans are fantastic, but occasionally you'll get a slightly odd result where you have to look at it again and think, well, actually, this doesn't really make sense. And I think that's probably where the GPs probably feel a little bit uncomfortable, because GPs are seeing, certainly in Queensland, some of the GPs might be seeing 30, 40 patients in a day. And so only a small proportion of those in a day will require them to go onto an online calculator, and if they have the time, to work out a FIB4 score. If I'm doing a liver clinic, we're pretty much doing it on every single patient for a whole morning. So I think that aspect of it needs to be taken into account, that primary care is clearly where it is all happening. But in terms of the volume of patients these people see, the variety of patients they see, it may not be at the top of their list of things to do.
Yeah, and going back slightly on that to Heart of Australia, do you ever get to jointly see the cardiac referrals? Because there's been a little bit of data coming out now that FIB4 predicts cardiac mortality. Not surprising. The American Heart Association have now added assessment for NAFLD in on their recommendations, and in fact comment on use of FibroScan could be the way to go. So if you now have cardiology commenting and the American Association of Diabetes adding in NAFLD assessment for standards of care for type 2 diabetes, you now have a van whereby is there a comorbidity option to be able to see these patients and work out that comorbidity management? Do you think that would be something that would be certainly a strength of Heart of Australia from what you were describing?
I think the answer to that question is yes, in that I would say that I've had conversations with cardiologists initiated by cardiologists who had been to a meeting maybe 5 or 6 years ago, where they approached me and said, well, look, we've heard that you can do this thing called a FibroScan, and we've heard that we should be looking at the liver. So this isn't something that's just suddenly happened. Obviously, with all of these recommendations, often the initial studies go back a few years. And actually, I remember going to an ARSL meeting probably 15 years ago, where the Kaiser group presented all their data. And at that time, time, there was no link between fatty liver disease and cardiovascular outcomes. And that was hundreds of thousands of patients. So it's only really been in the last 5 years where that link may have become a bit clearer, because up to that point, it was a little bit grey. It never made any sense. Of course, if you've got fatty liver disease, you're likely to have some poor cardiovascular outcome, but it's never really been demonstrated in a convincing way. So I think now cardiologists are more aware of that. And I think the Australian environment is very conducive to this, because many of the doctors, even all the senior doctors and certainly cardiologists in particular, are very protocol-led. And so if you have an American Heart Association guideline saying that you have to do this is something they will do. They just need to have an avenue to allow that to happen. Now, the issue in Australia is that obviously you don't have a Medicare billing code for a FibroScan, so that limits the availability a little bit, and many private practitioners, because obviously in terms of the Australian healthcare system, within Queensland for definite, I'm not sure about Western Australia, about 60% of most of healthcare happens in the private sector and about 40% in the public sector. So most of the public hospitals now when I say most, the public teaching hospitals in Queensland have a FibroScan, but the other hospitals don't. And so access for the public patients is limited to teaching hospitals only. And then if you look at the private practitioners, say for example in Brisbane, there are only maybe 2 or 3 private facilities that have a FibroScan and the others don't, because again, the billing is an issue and patients occasionally don't really want to have the test done if it's not going to be billable. So I think access is one thing, and this really goes back to the cardiologists. Once that guideline is taken on board and they want to try and access this, then they have to have a facility, and for it to be made easy for that to happen. So I'm still working on that in terms of thinking about it. At Prince Charles, we're a big cardiac hospital. It's a heart-lung transplant hospital, and they've got, I think 150 cardiologists there. We don't actually get many referrals from the cardiologists at the moment. All our referrals come from primary care.
You might have to look at all their FIB4s. Just as a background piece of, let's do a retrospective review of the cardiology FIB4s. So moving on though, medication is very likely to be approved to intercept, obviously, obeticholic acid and resmetirom by Madrigal in the next 12 to 14 months, probably is the time estimate. Are Australia ready to locate their population, find them, once we have access to very expensive drugs to treat something we currently know very little about, and what you're describing it there is have very little resources to be able to do it?
I mean, obviously the studies that have taken place, and Australia's been involved in some of those studies, I think there's a couple of issues. One is that the patient cohorts, I mean, if you look at all teaching hospital centres, I suspect everyone will have half a dozen patients in their clinic who would fit the bill for someone to go onto obeticholic acid right now. But in terms of having access to those cohorts of patients who are not within the clinic, i.e. still in the GP surgery, those numbers will be significant. And the drug may be TGA approved, but as you know, TGA approval is the first step. The next step is the PBS sort of guidelines around its use. And I think that will be a limiting factor in terms of what the allowance will be for people to be accepted to use it. Often the PBS guidelines can be quite strict. But having said that, you see, Australia led the way when it came to Hep C treatment, really quite remarkably, that they wanted everyone treated. And the difficulty for us now is that there are cohorts of people that are there, but we can't find them. And I suspect with NAFLD it will be very similar. If the government decide that this is something they really want to put their teeth to, if they have that sort of approach, I think, again, the easy patients will come, and these are the patients already on the systems, perhaps have been in a trial, perhaps just sitting in clinics getting a bit of vitamin E or something. But the cohorts, the hidden cohorts, will take time. And I think you're absolutely right about the cost, because the cost will be a big factor.
That's key. And we did an episode last week with Tim Jobson from Somerset, and they have a system that reads the trends in patients' blood tests over a number of years, so it can pick out all of your high risks, your medium risks, your low risks, so that you start with the, rather like the Australian Hep C system, you start with the cirrhotics first and then you work down and you start to cure. From my use of Cerner and electronic systems back in the early 2000s. I think those are where advantages I see in the Australian system. It may not be robust in having the data currently, but because of the systems it does have in place in primary and private and public health, the ability to read those systems and locate your risk patients may be greater than some of the other countries.
I really don't know about that because my experience in Brisbane has not been great with regards to the electronic systems. I mean, again, I don't know what the situation is in Western Australia, but the majority of hospitals in Queensland are not on the electronic system at the moment. It's coming over the next 10 years or something. But the issue that we've had is that System A does not talk to System B and System B does not talk to System C. And so you might have 5 different electronic systems, but none of them actually cross-talk. So I think the issue also will be when you're trawling databases, the next issue is then the ethical issues around pulling patients off databases without permission. I think there's a whole heap of things that one would have to think about. But I mean, it was a bit like the Hep C issues. In the UK, I know that you could go into a GP surgery and you could find old Hep C patients and then start offering them treatment. When I came here 10 years ago, I said, well, actually, why can't we just do that? And it was quickly closed down because of personal privacy issues. The rules are completely different. So again, that might require a bit of thinking.
Yeah, that was the comment last week, that we need to be using patients' data to help them rather than restrict us helping them by stopping using their data. If you had to think about where you see fatty liver disease going in the next 2 to 3 years here in Australia, what excites you, what frustrates you, and what do you think the obstructions would be?
To be perfectly honest with you, I mean, obviously we've just been through COVID, so it's been 3 years of not much happening. I think the most exciting thing that I've seen in the last 12 months has been the Saxenda and Ozempic use, which has gone from the diabetic cohort being pretty successful to amazing success with people who are taking it privately because they can buy their own supply if they can get it, and amazing stories of people, seeing people who've lost 20, 30, 40 kilos over the last 12 months. And so whilst we don't have anything else, I personally see that as the interim solution. Now, obviously, I don't know what happens when they stop taking Saxenda or they stop taking Ozempic. We don't know. And I always say to the patients that it's not just about the weight loss. The habits have got to change as well. Otherwise, once you stop taking Ozempic, if you've got the old habits, it's all just going to come back. So I think that's been exciting to see because you see people really doing amazingly well, where the only option previously was weight loss surgery. And people who've been in this game for a long time realise that weight loss surgery is not always what it looks to be, because 15 years down the line, actually your weight may be back up to where it was before. So I think that's been good. I think the next mission for public health will be actually education. And I think in terms of the priorities for all the gastroenterology and hepatology associations and the learned societies is now to start petitioning strongly for the fact that in 2050, this is going to be a terrible, terrible problem with lots of people who have no curable outcomes, because by 2050, these numbers of people who are cirrhotic, or by that stage will be cirrhotic, will be huge. And, the biggest transplant programs in the world will not be able to cope with these people. And it's really now that people have to start thinking about it. So I think going into the future, yes, the antifibrinolytic drugs will be great. And for the right patients, it will be fantastic if they can tolerate the side effects of what happens. But I suppose that's stage one, isn't it? And as we've seen with interferon, that was stage one. And then we ended up 2 decades later with amazing medication with no side effects that was totally curative. So I think this is the beginning of that journey. And yeah, I mean, 10, 20 years time, I suspect this is going to be something that will probably not exist. Well, one hopes.
That would be a great outcome for any of these new medications. And I could listen to you talk about the role of Australia and where it's going all night, but I've taken up way too much of your time. I'd like to thank you, and I'd love to ask you back at some stage with some more KLO. We're going to get, hopefully, the Australian Liver Foundation on to have a conversation with their initiatives and that in the future, and it'd be great to have you on again, and maybe Heart of Australia to see what we can learn. But I think it's sharing these initiatives around the world that allows us to pick and see what works, doesn't work, and continually readapt. But I think you've been clear that we've got a pandemic of fatty liver disease, and I think Australia is leading the world in liver cancer. It's about getting that knowledge out and giving people the opportunity for liver health rather than liver illness. Changing that paradigm, the Australian government could drive it. Certainly, I think most countries around the world use ultrasound elastography as their code for FibroScan, even though it's not. And I know that's used here. Thank you very much for the time and staying up so late, because I appreciate this midnight in Brisbane and a couple of hours behind you here in Perth.
Absolute pleasure. Thank you, Louise.
And now for the Season 4, Episode 6 Business Report.
Slava Ukraini, Heroyam Slava. Glory to Ukraine, glory to heroes. As you know, I've been on vacation most of the past week and not following world affairs as closely as usual. That said, most of what I read this week has focused on the one-year anniversary of the initial Russian attacks, which will come on February 24th, and these articles question what Russia will do to mark that date. Let's hope that the resolve of the Ukrainian people, backed by new arms from Europe and the U.S., fortify them against any upgraded attacks. And again, Slava Ukraini.
It feels like a weekly thing to announce revisions to the future episode schedule.
Compared to last week's updates, these are minor revisions focusing solely on this week and next. For the reasons I described in the introduction, our larger focus on Australia will have to wait a month or two until Louise is back down under with time to work on this. So, this week was scheduled to be a full episode on Australia. It was an introduction. Next week was scheduled to be another episode on Australia, but I just got back to work today. We'll have a great topic by Monday. I've seen 2 or 3 publications in the last couple of weeks that would be great episodes if we can get the authors to join us. We'll let you know what we come up with early next week.
From the vault, some thoughts on patient advocacy.
This week's vault comes from last May, Season 3, Episode 25.5. German patient advocate Achim Kautz and Andrew Scott, who at the time was the Global Liver Institute's Vice President of Policy and Public Affairs, joined us to discuss exactly what patient advocates do. In this final section of the episode, they shared what they consider 2 key areas of focus for future organizing and advocacy. As you reflect on today's Australia interview with Tony Rahman, it might help to consider what is working now, what might work better, and how any of this relates to the excellent advice that Achim and Andrew gave us last year about patient advocacy and support.
January turned out to be a banner month for downloads.
Last week I said, and I quote, "After a really anemic start, January 23 is on track to be among our 5 best months ever, maybe even top 3. So much for that prediction. January actually finished as our strongest download month ever. And February has started out remarkably well these first 2 days. Not to harp on this, but the one thing that will be even greater is when you folks start sending us reviews that make their way back to us and boost our ratings in the Apple system, pod status, and the other places that matter to us. Enough said about that. So, for that, I'm off. Thanks to Jake, Magic Mike, and Louise for pulling things together this past week despite my vacation and Louise's challenges, and hoping that the medical issues in her family are resolved quickly and happily for everybody involved. So, stay tuned for the weekend conversations, which will come on Saturday and Sunday, and join us Monday for an excellent new topic. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.